Good evening, everyone. I welcome you all to the series of webinar being hosted by Gwalior Division of Ophthalmic Society. The first has already been happened. This is the second one on series, and this is from PHACO from Basic to Advanced. PHACO Pearls and Basic to Advanced. I thank all the faculty and the invited guests for having accepted the invite and given your precious time to the Gwalior Division of Ophthalmic Society. We thank you once again. Sorry. Sir, the webinar is on. Sir. Unmute. So we'll begin with the introduction being headed by Dr. Abha Shukla Madam. Dr. Abha Shukla Madam.
Yeah, very good evening to all of you.
And kindly introduce the speakers. Dr. Basim would be joining soon. Just call.
Very good evening to all of you. I welcome you all on behalf of Gwalior Divisional Ophthalmic Society. COVID has given us, this pandemic has given very difficult time to all of us, but this webinar series has really a boon to all of us. It has education has been continued. I would like to introduce all of our speakers. First, Dr. Suven Bhattacharya ji. He is consultant at Nayan Eye Center, Kolkata. He is inventor and entrepreneur. He is founder of Medical Invent Device Private Limited, which is a startup with many awards. He has also got international patent for his invention, the BHEX Pupil Expander, which has redefined pupil expansions in cataract surgery. He received gold medal at the Lockheed Martin India Innovation Growth Program. He has been awarded with many awards in AIOS, Dr. P. Shivareddy International Award, Colonel Ramacharya Award for Overall Best Paper, Santi Vision Award for Best Cataract Paper, ASCRS Best Paper for Session, AIOS International Hero Award, CS Reshmi Gold Medal Award for Best Video, and APA CRS. Second speaker is Dr. Ranjan Gupta. He is a phaco and refractive surgeon. He is at present holding the chief of Ranjan Eye Heart and Laser Center, Tohana, District Fatehabad, Haryana. He is associated with many institutes for laser surgery in Haryana like Sirsa, Hisar, Bhiwani, in Mansa, Punjab. He has did his graduation from Bhatat, his post-graduation from Nagari Eye Hospital, Ahmedabad. He did his LASIK training from a renowned, the first, I think, Super Shah's New Laser Vision Center, Vadodara. He presented talk on Topo line in Tamil Nadu Conference, Chandigarh, Ahmedabad, Patiala, Gurgaon, various Chennai and Delhi conference. He is mainly interested in LASIK and phaco surgery. Our next speaker is Dr. V.K. Nichalani, sir. He is the president of, the head of the Institute SV Eye Care and Research Center at Bhopal. Presently, he is the chairman scientific committee of our MTSOS institution, and he did his his training from Eye Institute, Navsari, Gujarat. He worked in Seva Sadan Eye Hospital also. Thank you, sir, for being with us. One of our speakers is also Dr. Lieutenant Colonel Prajakta Dandekar. We are happy to be with us. She is graded specialist ophthalmologist in Military Hospital, Gwalior since June 17 till now. He did his phaco fellowship from Shri Sadguru Netra Chikitsalaya, Chitragut. He published various papers in Teresium. I am very much fascinated by her extracurricular activities, and I would like our youngsters to follow all these various activities because they are very relaxing and soothing in this stress of time. She did her para basic education course, para jumps with the armed forces. Chief of Armed Staff Commendation Card for Demo Para Jump MOBC 183 course at OTC Lucknow. She had cleared intermediate in drawing. She also liked tandem skydiving, and she did at Las Vegas, deep sea diving at Andaman. Andaman. Thank you with us. Thank you for being with us. Dr. Rahul Shukla, he is also with us this evening. He is Medical Director of TN Shukla Hospital, Jabalpur. He did his fellowship surgeries. He did a charity eye screening at operative camp at Nairobi. And our local speakers, Dr. Bhasin sir, Dr. Bhasin, Dr. O.P. Agrawal, he is from Indore. Dr. O.P. Agrawal, he is the director of Rohit Eye Hospital, and he is very famous for various, he demonstrated good light surgeries during our conferences. I welcome all of the speakers. Now I share the screen with Dr. Manav. Dr. Manav.
For a brief introduction of all the invited guest faculty. Dr. O.P. Agrawal, probably sir, has he joined? Raman, can you check Dr. O.P. Agrawal sir, has he joined? Fine. He hasn't. Fine. Then we'll get started with the first presentation today. And I welcome Dr. Abha Shukla, madam, to start the first topic, and her topic is pearls for beginning phaco surgery. This is very important for the final year students as well as the ones who have just started phaco emulsification. She'll give her pearls and her experiences she'll be sharing on phaco pearls. Madam, kindly, you can start your presentation, madam.
Yeah. Thank you, Dr. Manav, for kind words. All the ophthalmologists, ophthalmic surgeons and society is fascinated by the phaco surgery. The reason being very simple. Small incision makes visual recovery early and no lockdown period for the patient. For decades, the road to phaco surgery was scary and stiff, but now with the availability of excellent training institutes all across the country, advanced and economic phaco machine models, the road to phaco surgery, highways to phaco surgeries are really enjoyable. We can start reading books to learn the phaco dynamics. Details of surgical steps can be understood by watching videos, attending webinars, attending surgical skill transfer sessions, being held in various conferences and workshops. Handling of phaco probe and working of foot pedal can be nicely understood by practicing in the wet labs various surgical steps either on the plastic eyes or on the go side. Start performing functions with your non-dominant hand, especially left hand in the right dominant person. Schedule a training. Training will not only give you exposure to various surgical steps and give confidence, but during training you also associate with a mentor who can take over during your complication, act as a savior during learning phase. You can record all of your cases and watch back in real time. Later on, you can discuss troubleshooting with your mentor. Many steps of SICS you can practice during the many steps of SICS you can practice. Many steps of phaco surgery you can practice while doing the. My voice is audible, or the music? Like the 2 ports, rexis, and small incision. You can initially. So many steps of phaco surgery you can practice while doing the SICS. Like making the 2 ports, rexis. Rexis is very important for. It is the first step for doing the phaco. You can make a routine tunnel of SICS, and initially you can just enter with the 2.5 or 3.2 S for your diameter of phaco probe. Initially you make a small incision. Through this you can practice various hydro procedures, hydrodelineation, hydrodissection. These are again very important to debulk the nucleus. Here you can also learn the nucleus rotation. So during the SICS you can also practice the nucleus rotation. Later on, you can convert this rexes into multiple can openers. Like I always say, take 3, you can practice 2 for the postgraduate. So this small incision you can manure, you can learn to manure the phaco probe. Initially, you can make the trench. So this way you can practice many steps of phaco surgery during your routine SIC surgery. So when you start, now you have trained in SICS in an institute. Now when you start surgery in your own in your own setup, you should become familiar with the phaco machine and with the microscope. You must learn about the setting of phaco machine, handpiece, foot pedal, phaco tips, diameter, bevel or angle design. Phaco, subsequent speaker, Dr. Bilal, will be discussing about the phaco dynamics. So you must get acquainted with your machine's phaco dynamics and about your microscope. Use appropriate magnification to see the details as well as the surgical print. Use foot pedal control for increasing the magnification. Keep the eye center. Initial 20 or 40 cases, good case selection is very important. You must select a proper case, a simple case, grade 2 or grade 3 density of the nucleus. Pupil should be well dilated. You start doing under the good block. Later on, once you become comfortable, you can use topical anesthesia, like we'll be discussing with other specialists. Complicated cases like dense nuclei, small pupils, pseudo-exfoliation, compromised corneal endothelium functionized, which will be cases which will be subsequently discussed by the renowned speakers. Those complicated should be left over for the experts or when you get expertise. While surgery, you should be patient, avoid distraction, have a backup plan ready because increased risk of adverse event add to the stress. Success is a more potent confidence builder than failure. It depends where you start your journey. It determines where you finish. So you must know your team, know your equipment, talk to patients, take your time, be honest, have a backup plan, record and watch your surgery, focus, keep track of your outcome, never stop learning. So learning can never be stopped like we are doing in this pandemic also with all this difficult time. And whenever you find difficulty at any step, reverse challenging steps, you are working again in the wet lab or on the surgical simulator. Thank you very much. Thank you.
Thank you, Dr. Abu Shukla ma'am, for having stuck to the time and having shared a wonderful presentation about how to start off on your pearls for beginning phaco surgery. It's very important for the phaco neophytes to understand how do you switch. Thank you for your valuable time and this point. I'll now request Dr. Bilal to share his presentation on phaco dynamics. Dr. Bilal?
Yes, sir. Am I audible, sir?
Yeah.
Is the screen visible?
Yes, Dr. Bilal.
Okay. Thank you so much, sir. With a special note of thanks to the organizers, I would like to straight away begin with my presentation. Since its invention in 1965, phaco emulsification has undergone a lot of changes, but the laws governing the procedure are still the same. Phaco dynamics is basically a study of ultrasound power inflow as well as outflow. So the inflow and outflow part combine of what we know as fluidics. The know-how of these is essential for an effective delivery of adequate power so that we have no collateral damage as well as we achieve our desired results. Without diving straight forward into the phaco dynamics part, I would like to give a brief introduction about the parts of the phaco machine. You have the internal pump, the phaco handpiece, as well as the foot switch. So talking about the internal pump, it forms the aspiration system of the machine. You have peristaltic pumps, venturi pumps, diaphragmatic pumps, as well as rotary vane pumps. The peristaltic pump is what you see is a series of rollers that are set on a rotating wheel that perform milking action of the aspiration tube, thereby drawing out the fluid. Whereas in venturi pumps, you have a column of air that flows from an area of high pressure to an area of low pressure, thereby creating a vacuum. So the important point here is in peristaltic pumps, it takes more time for the vacuum to reach the preset level and is thereby recommended for beginners. Coming to the phaco handpiece, you have the irrigating fluid flowing between the tip as well and the silicone sleeve that performs cooling of the phaco tip. In the phaco tip, you have varying degree of angulation, but the 30-degree tip is the most commonly used. There are basically 3 connections to the phaco handpiece, one for the power cord, one of the aspiration line, and one for the irrigation line. The third component is the phaco foot switch. You have 3 positions along the vertical excursion of the phaco foot switch. Position 1 activates the irrigation system. Position 2 activates the irrigation as well as the aspiration system. And the position 3 activates irrigation, aspiration, as well as the ultrasound power of the machine. To understand the working of the phaco machine, you need to be aware about certain terminologies. So talking about irrigation first, we have basically 2 types of irrigations, passive and active irrigation. Passive irrigation is the more commonly seen type of system, where you have gravity governing the amount of fluid that is flowing into the eye and is determined according to the bottle height that the surgeon has set. Active irrigation is a relatively newer phenomena where you see where you can actively control the amount of fluid that flows into the eye by means of various sensors. The thing that you have to keep in mind is that always keep the inflow equal to the outflow from the eye. The outflow is what you see coming out of the eye from the aspiration line, as well as what the leaks out from the phaco wounds. If you take care of this, you'll have a stable anterior chamber for your surgery. Talking about aspiration flow rate, it is the amount of fluid that is aspirated from the eye in cc's per minute. It is somewhat similar to what you see at the poles of a magnet, where you have magnetic fields. Similar to this, you have eddy currents in the eye that attract loose fragments to the phaco tip. That is called followability or attractability. Third term is vacuum. It is when you have negative pressure inside tubings and it holds the loose fragments to the phaco tip tightly. The important part is that in peristaltic machines, you have vacuum building up only after there's complete occlusion of the phaco tip. But a safeguard mechanism here is called as venting, which can be air or fluid mediated. When there is occlusion of the phaco tip, the vacuum gradually builds up and the tubing collapses from within. But once the fragment is aspirated or removed, the tubing again rebounds, thereby the large amount of fluid is drawn out from the AC and can lead to various complications. This is called as surge. The only way of preventing it is by anticipating it. So what you need to do is you need to step down your parameters when you're dealing with the last nuclear fragment. The last term is ultrasound power, is basically a product of frequency and stroke length. Frequency is basically constant for a given machine, and most machines operate in the range of 28 to 60 kilohertz, while the stroke length is variable. Stroke length is basically the length of excursion that the phaco tip makes. So when we are talking about changing power on the panel, we are basically talking about changing the stroke length. The ultrasound power that you have can be delivered in various modes, but the ideal site of delivery for the ultrasound power is in the bag and in the central safe zone. There are phaco continuous modes where you have a continuously linear increase in the amount of phaco energy that is delivered as you go in the foot position 3, while as it can be intermittent in cases of phaco pulse and phaco burst modes, where you have the terminologies of phaco on time when the ultrasound power is delivered and phaco off time when you have no power being delivered. So the take home messages that I would like to give here is understanding phaco-dynamics is the forms the basis of performing a good phaco procedure, and optimized use of phaco power along with technology will help us attain clear post-op corneas and happier patients. The thing that we have to keep in mind is that we need to balance the ultrasound power as well as vacuum, also as to where we are applying it. Thank you.
Yeah, thank you, Dr. Bilal, for the wonderful presentation. We must all understand the machine first as we get started with phacoemulsification. And obviously, it's very important for the phaco neophytes or the postgraduates who've just started to do phacoemulsification to understand the machine first and then go ahead with the better procedure. Thank you, Dr. Bilal. And now request Dr. Rahul Shukla, our invited faculty from Jabalpur, will be sharing his presentation on capsular excess sizing and centration, an important step in phaco emulsification. Dr. Rahul Shukla, please.
Yeah. Is my screen visible?
Yeah, Dr. Rahul.
Fine. At the outset, I would like to thank World Division of Ophthalmic Society for giving me this opportunity. Greetings from TN Shukla Eye Hospital, Jabalpur. A very good evening to everyone. So we've heard two great talks about what phaco emulsification is all about and how you learn about it. And second is the machine. Now let's talk about the steps. Dr. Abha already mentioned that you can always start practicing CCC even when you are doing a ECC or an SICS. So I'll be just focusing on the capsular excess sizing and centration. Yes, a decentered IL accounts for around 37% of the postoperative refractive surprise. This is true, quoted by Dr. Warren Hill. And the wrong IL power accounts only for 17% of the surprises. So a decentered IL really plays a very significant role. So there has been a study which was published in the JCRS wherein they studied the effects of the decentration on the tilt at different orientations and optical performance of IOL. And they found that the decentration obviously at times it induces and increase or a decrease optical quality. And obviously if it is too decentered and the IOL is a bit tilted, there's loss of optical quality. And when it comes to the premium IOLs, let's talk about a few forces, the basic physics when you are actually wanting to do a CCC. So whenever you are rotating around a central pivot and you are in a round motion, there is a force which actually pulls you out, that is the centrifugal force, as you can see on the left side. And there's another force which actually pulls you in, that's your centripetal force. So whenever you are operating, the centrifugal force actually comes into play wherein your axis goes out, it extends. And you have to actually pull in by using the centripetal force. You have to make sure that you have to balance these two forces, otherwise the extension is going to be there. And let's talk about a few more words. One is an intralenticular pressure, that is pressure inside the lens, the cataract. And then second is the extralenticular pressure, that is the pressure in the anterior chamber. In short, the more intralenticular pressure, the centrifugal force will dominate and the axis extends. Whereas if you have more extralenticular pressure, the centrifugal force does not dominate and the axis will not extend. We can obviously control both these pressures by frequent use of heavy OVD, preferably a cohesive OVD initially, and then manipulating our instruments to control these two forces. Without going into much detail, let's talk about this by showing a few videos. So this is what I have done, and I have actually, I'm confident in doing CCC. I fill my AC with adequate OVD, and this raises the extralenticular pressure. I always use a corneal ring marker, that's a 5.5 mm and ring, and it gives me a good reference of the sizing of the CCC. I remember that my forces are up and down, and I keep on pulling the axis in, and I make sure that the flap is flat over the capsule. So these are the initial steps. I keep on making sure that I keep doing them, and I am just able to cover the optic edge 360 degrees. Well, that is our initial goal. I prefer using the capsulotome and making it under the microscope. I enter with the tip sideways, less OVD comes out that way, and I turn the tip when I'm in the AC. Again, stabilization of the iris, because I'm doing under topical. With the iris depositor, I stabilize the eye. And I remember that I keep on using all the things mentioned. I fill the OVD properly, my capsule is lying flat, the flap is lying flat, and I'm able to do the rotational movements, whereas my corneal ring marker is giving me a good reference. The same principle applies when I'm using a retractor forceps. Mind you, with the retractor, a bigger instrument in place in the wound, there is more OVD which is going to come out. So you have to replenish the OVD more frequently, as you see I am doing. But then again, you have to make sure that your reference mark comes into play. Let's talk about a soft cataract. The intralenticular pressure here is more. I make sure that my OVD is filled well. The reference mark again is going to help me. And I start with a smaller CCC. I start with a smaller CCC, and I keep on making sure that I do all my movements as I have mentioned previously. Keep practicing, and it's in the last step, as you can see, if it's extending, I'm actually pulling it towards the center, and this is the amount of pull which you apply to make sure that your CCC gets to your desired centration. You get a perfect centered IOL. Go a step further, try a soft cataract with a toric IOL. Again, the CCC is going to be there, but this time, as we go in for premium IOLs, a toric alignment is paramount, but then the centration of the IOL is important. And I do not hesitate shifting between a forceps and a RIX and a capsulotome as and when needed. As you can see, again, a perfectly aligned IOL. Now, extending a CCC, at times you make a small CCC, and there's this ribbon of the capsule which keeps on extending accordingly, and this ribbon has a tendency to come out of the incision. So what I usually do is I cut the ribbon, extra ribbon, so that it doesn't come out, and I'm able to control my extended CCC. And then finally, the urging and flat sign, the most complication. People say femto would be the better option, but I prefer is I use a cohesive OBD to rate the intralenticular pressure. I do a fast small CCC with the rexis, again pulling the CCC towards the edge towards the center. And I usually go in with my PHACO probe and I debulk the cortical matter, the semi-solid and the liquid cortex. That way, I have already made sure that the CCC will not extend. I can always enlarge my CCC by giving a nick using the rexis forceps again. And the corneal ring reference again guides me in getting a perfect size, and the lens is centered, as you can see in the next slide. So this is what gives you confidence. Let's go to another case where in a mature cataract with toric IL under topical. Now these are cases initially you would like to give a block, you would be very skeptical about how the toric IL would be implanted, but it's practice, and the reference mark along with the circular small motions and keeping all the principle in mind, you are able to get that. Let's talk about a small pupil. Dr. Savani is here. He would be more than happy to see this video. This is a topical anesthesia case wherein I am enlarging the pupil with the B-hex ring. I'm able to get a 5.5 mm rexis, and under topical, this is the perfect toric IOL. Dr. Bhasin sir, who's going to talk about the post-RK cases. This is one of my cases wherein I was able to implant a toric IOL in a post-RK case, a perfectly aligned IOL and a perfectly centered IOL covering 360 degrees. And these are the cases wherein you can use, it's your dream to do these cases under topical, but then you have to start at the very beginning. And this is another case of a multifocal IOL toric with a properly centered CCC and a well-aligned IOL. And according to me, this is one case, and this is our dream come true. Like if you are able to cover 360 degrees optic edge and you are able to align the IOL properly. And obviously, it is possible, because if I can do it, anybody can do it. It's just you keep on practicing. We have another rexis by Zepto. It's a very useful instrument in intumescent cataract. The cost is a factor. You still need to center it, and it's a bulky instrument which goes in the eye, and the part which goes in the eye has to be replaced. It's a disposable thing, so it comes at a cost. And then we have the femtorexis. Obviously, femtorexis is desirable, but at what cost? And is frankly femtorexis worth it? Femtophaco could be worth it. Is femtorexis worth it? Dr. Uday Devgan from California, he did a study and he said he was very happy in intumescent white cataracts because it avoided the Argentine and flat sign. And obviously in brunescent cataract with the posterior polar defect, obviously that helped him. But what about his routine cases? So in his study, he said if you have a good manual rexis and a perfect femtorexis, but mind you, both should overlap the optic edge 360 degrees. He didn't see any clinical significance in the post-operative refraction. So, and these are my rexis, wherein I've already showcased these three photographs in the videos, and here again. So my corneal ring marker actually is a poor man's femto. This is Dr. Robert Osher's statement. He keeps on saying if you can use a corneal ring marker, you would be able to perfect the CCC, and you will be able to achieve it, and multiple times you'll be able to achieve the desired size. So my take-home message is the intra and extralenticular pressures along with the centrifugal and the centripetal forces to be kept in mind. You should be able to make a good capsular tome initially, because that is important. A 5.25 to a 5.5 mm rexis is desirable. Replenishing the OBD frequently, be proficient in using a capsular tome and forceps whenever you need. Practice is important. And switching between instruments as many times as possible. Don't hesitate to shift to another instrument. And the flap should fly over the capsule while doing the CCC. And I need to be patient, and everybody needs to be patient. It's doable. Thank you so much for your patient hearing.
Thank you, Dr. Rahul, for a wonderful presentation. How to start off with the rexis and keep it perfectly centered. It's been a great learning from your video presentations also. I know from my experiences that once the rexis is fine and it's well centered, you can go ahead and do a cataract surgery. One of the most hardest cataracts that you possibly can get to do. Thank you for your presentation, Dr. Rahul. We'll now move on to Dr. Purinder Bhasin sir. He'll be presenting upon PHACO in post-RK eyes. Radial keratotomy has been defunct and not being practiced anymore, but we do get to see a lot of post-RKIs, and we've done retinal surgeries also for them. But certainly they pose a lot of challenge out as to how to get IOL power and also to do rexus and cataract surgery in these eyes. Dr. Bhasin will shortly be presenting his present.
Hello. Hello, Dr. Mano.
Sir.
Can we have the comments, or we are going to have it at the last?
No, sir. We have time to take your views and your expert comments, sir.
No, I thought you will be inviting the comments from the others.
We had kept them to the end. We had kept them to it, but please, sir, we can get started with a couple of questions. That's perfectly fine, sir.
Since there is some time, maybe Dr. Bhasin is preparing.
Yes.
Just one comment. I would like to share with Dr. Shukla. A very good presentation, and the poor man's marker is a wonderful concept. I'm really happy with that. But pushing the visco, it really works very well. Especially the Argentinian flex sign situation, where there is very high intralenticular pressure. Maybe you can use Hilon or some heavy weight so that it keeps anterior capsule flattened to perform the rexus. Sometimes whatever you do, even attempting to make a very small rexus like 2 millimeters, you are going to have an Argentinian flex sign. You just cannot prevent it sometimes. So here the role of the femto comes. So maybe Dr. Purendra Bhasin will be talking about that. Yeah, Rahul, you wanted to say something?
Yeah, I mentioned that, sir, heavy OVD, cohesive OVD is needed. Hilon 5 is an ideal thing, but still, sir, you get, so that is the reason, sir, femto scores when it comes to intermittent cataracts and preventing the Argentinian flex sign. Obviously, it scores. I mentioned that also.
I think it all depends on what Dr. Rahul has presented very nicely, and Dr. I really appreciate the point which you have raised, which is a point of discussion for everyone. And even after taking all the precautions, you land up with the Argentinian flex sign. Dr. O.P. Agarwal is also there, and Dr. Suvain is there with us. So all the students and Manav and all the faculty here is quite experienced. So another thing which I do is that I make the rexus through the paracentesis incision. So chances of leak from the main wound is high. So if you do it through the paracentesis incision, so the pressure, the force which keeps the anterior capsule flattened is maintained throughout the procedure what we do. And it all depends on the intumescence of the cataract intumescence and the intralenticular pressure which we call. So if it is more than whatever you do, it is going to happen. And if there is a leak in the anterior chamber with femtosecond laser, you can land up with an incomplete rexus. So this is what I have also, because the milky fluid comes in between, and although with the catalyst machine, you can do rexus in 13-14 seconds. That is fast rexus we do now, and in 12-13 seconds we can finish it. So that is what it is, but still it can happen, and the rexus margins are incomplete, and you have to see or check it before you start or take out the anterior capsule from the anterior chamber. So with this,
very good point.
Can I make a comment?
Yes, sir.
Okay, I have 2 comments. Excellent presentation, Dr. Rahul.
Thank you, sir.
Just 2 comments, 2 additions maybe to add on, especially for our younger colleagues. When we have a capsular rexus run out, when we're having a run out, the tendency is to inject viscoelastic. Now, and naturally we tend to inject viscoelastic right in the center of the anterior chamber, and that invariably will lead to an extension of the capsular rexus periphery. So it's very important to realize that when you inject viscoelastic, you go and inject viscoelastic more at the periphery where the run out is happening. So if you do that, what happens is if there's any milky cortex over there, that kind of gets pushed out, and the intralenticular pressure over there is reduced. So that allows you more control. And of course, there is another thing is I would have liked you to mention about the Brian Little's capsular rexus rescue, where you just flatten it and back and then pull it more centripetally.
That's the reason I showed that, sir. I slow motion it, and then you have to actually literally pull it to the other side.
Yes, yes, you did show it in your such when it was running out once. Yes, that's a good thing. Yeah, thank you.
Can I just add a comment on the same thing? It is like this: the intralenticular pressure, which is on higher side, before starting capsular access, if we take a 30 gauge needle in a tuberculin syringe, puncture the anti-capsule right in the center, and try to suck whatever the liquid material is there, that completely reduce down the intralenticular pressure. And then thereafter, probably there won't be any need of putting any high density viscoelastic and all those things. You can, I would say, complete capsular access with a normal routine viscoelastic. So this is a practice I've been doing since long. Thank you.
Shall I?
Yeah.
Thank you, Dr. Manav, for giving me this opportunity to share my experience of working on post-RKIs, doing phaco in post-RKIs. So I don't have any financial interest. So we do come across with the, as Dr. Manav said, that we do come across with the, one second. Yeah. With the cases of cataract post-RK. So because of their irregular corneas, even the mild cataracts can induce visually significant aberrations at an earlier stage. So this is what we have seen, that early cataracts also are annoying to these patients. So coming to the challenges in post-RKIs while doing phaco, the first and foremost thing which we come across is the inaccuracy or the challenge in calculating the IOL power, which we have to.
Your slides are not showing.
Oh, one second.
Your slides are not showing.
Purendra, you need to open your presentation and then start the screen share.
Okay, one second. The presentation is open. Let me check.
No.
Is it
Close
visible?
your presentation. Close your presentation. Close the screen share. Open your presentation, then start the screen share.
Okay. One second.
It's a new addition for the new Zoom. I mean, this is a new change with the Zoom, I think, has introduced.
What is that, Rahul? Close the presentation.
Stop share. Karo.
Yeah.
Well, sir is preparing. We can take a few questions from Dr. O.P. Agarwal, sir, if he's there.
Yes. Yeah.
About centration of the rexus and sizing of the rexus, if at all. O.P. Agarwal, sir, share your...
Actually, we have Varion. So with the help of Varion, because nowadays we are doing each and every surgery with the help of Varion only. So the site of incision is exact, whatever we calculate pre-op, and we have to take the incision in each and every patient at the proper axis. Number two, size and centration of capsular axis is very well we can plan with the help of Varion. That is a very good tool which helps me like anything. Whatever size we want, and the centration is exact. Sometimes our assistants or whosoever comes in our OT, some ophthalmologists come, they usually say that this is like manual robotic cataract surgery, like manual LenSex we have done. So the centration as well as the size can be done very well with the help of Varion, that is image guided tool which we are having. Though that is a big investment, but my suggestion for each and every ophthalmologist is, if we can see pupillary margin, you just see the pupil. If it is properly dilated pupil, then it will work like a image guided assistance, because if fully dilated pupil or semi-dilated, slightly less dilated pupil will give us a idea to all of us, so that we can do a centered capsular axis with the help of pupillary margin. So that is what I suggest. As Dr. Rahul also suggested that we can use an impression over the cornea, which usually I don't like because that impression will remain for some time. But that is also a good idea to do centered and fixed capsular axis.
Is it visible? Can you see the screen now?
Purendra, can I just suggest?
Yeah.
Purendra, you stop sharing the screen, and now your folder is open. You open the PowerPoint after that. Stop the sharing of the screen. I've sent you a private message. If you just can check it. Stop sharing the screen. Open the PowerPoint. You're just opening the folder. Open the whole PowerPoint.
Okay.
And then start sharing the screen, and then go to full screen.
And one more thing I would like to talk to all of you for capsular axis. That what I saw most of newer generation ophthalmologists, they do capsular axis through side port incisions. They usually prefer two side port incisions, and they try to do capsular axis from side port incision. I prefer to do capsular axis from the main port. That is much more easier and can be controlled in a better way. That is my experience.
Thank you, sir, for all the valuable tips that you just shared.
And whatever we were discussing about extension of capsular axis in very hypermature white cataracts. What sometimes we do, we just give a small nick. If it doesn't extend, then try to aspirate the milky fluid from the capsular bed. It will reduce the capsular pressure, and we can do capsular axis even in this type of cataracts in a very comfortable way.
Sir, thank you.
Click on slide, so yeah, it's fine, sir.
So shall I begin? Sorry for the interruption.
What about your screen?
Can you see my screen?
Yeah, now your screen is fine.
Okay, so because of these irregular corneas, the cataracts can induce, can be visually, even the mildest of the cataract can be visually significant. The challenges are, the first and foremost is the IOL power calculation, which is most of the time quite inaccurate, and we'll discuss it further. And the other thing is to take care of the RK incisions on the over the cornea, which are of more than 90% depth. And the post-operative recovery can be unusually prolonged because of the flattening of the cornea, and the cornea takes long time to come to the normal stage. And all these patients are more demanding and intolerant to residual refractive errors because they have been very happy with the good vision pre-operative before the development of their cataract. So coming to the first thing, why there is a inaccuracy in the IOL power calculation. That is just because the cornea becomes flat after, in the cases when the RK incisions are made, and the keratometric errors are there in these eyes. The RK flattens, with these RK flatten, the incisions, the central small zone, it gets flattened, and it is almost similar in the anterior and posterior corneal surface. Some people have said that the posterior surface is more, anterior surface is more steeper than the posterior surface, but this is, but most of the people think that both the anterior and posterior corneal surfaces are flattened. Unlike in the LASIK, in which the anterior surface is more flattened as compared to the posterior corneal surface. So this happens in a small central optical zone. And this effective optical zone diameter is smaller than the measurement zone of the standard keratometry. We all know that the standard keratometry is measured through the 3.2 millimeter of the center of the cornea, or the area where we are measuring it. But this zone is smaller or lesser than the area of calculation by the standard keratometers. Therefore, there is an overestimation of the corneal power, resulting in implantation of a lower power IOL. So there is a residual hyperopic refractive error in the post-operative period, which we find more common in these patients. So the thing is that we implant lesser power because the cornea is more flattened what we measure. our corneal keratometry can be of 35, 34, 33, 29 like that. It all depends on the number of incisions which has been made and created. To prevent post-operative hyperopia, a more myopic result can be targeted, such as -0.75 diopter instead of typical 0.25 diopter. And the other important thing is that we should use a flattest central K on topography for the IOL power calculation. And multiple keratometry with varying diagnostic devices such as pentacam or dual Scheimpflug analyzer or other means should be done, and we should try to get the measurement in the small 2 millimeter or 3 millimeter optical zone. What we do now, what I do nowadays to check it and find it. So this is what it is. The power of the cornea is a combination of both anterior and posterior corneal surface. So in post-refractive eyes, whether it is LASIK or refractive, the anterior-posterior corneal variation occurs, and we take a standard constant for the corneal power, which changes because of the change in the ratio of anterior and posterior corneal surface in these post-refractive patients. So by converting the overall central corneal power from topography back to the anterior corneal power, then subtracting the expected posterior corneal power, we can achieve a fairly accurate estimation of K for our IOL calculation. This is the formula which has been suggested by Robert Maloney, and I don't know how effective it is, but people have recommended it, but I have not used it. I use either the AS-Series, the formula which is given there, or I use a standard K, which is of the smallest diameter K which is there, and multiple K readings I choose, and I choose the highest power which has to be implanted. I don't use a lower power to achieve a better results, and still we get a hyperopic surprises in these all cases. Coming to the next important issue, that is a surgical consideration. These RK incisions are weak and are prone to open during the surgery. We should avoid cataract surgery incisions intersecting the existing RK incision, as they can unzip and cause excessive fluid leakage during the surgery. To ensure safe surgery procedure, I prefer lower flow rate and lower bottle height. And the important thing is that we should always opt for a 0.5 to 1 millimeter scleral incision. So this will prevent the ripping up of the existing RK incision. And we should always plan to use a smaller phaco needle, which are possible, 2.2 millimeter or 1.8 millimeter, whichever is possible and available with us. Now this is a normal case, how we can do. There are more than 16 incisions in this particular case. And I'm making capsular access through my side port incision or paracentesis incision to avoid any leak of the viscoelastic. And you can see there is a rim of sclera that I made a scleral incision. All these eyes are quite deep, so at times you have to go, you have to raise your phaco handpiece, and that can strip or unzip the zip of the phaco incision. So these rim of sclera, this prevents the opening of the phaco wound. Then sometimes it has been said that we cannot do femtosecond capsular access or femtosecond laser in these cases because of the presence of the phaco or RK incision. But I have done it in many cases and I don't find such problem, such issue. And even if there is a scarring of the RK wounds, we can finish it. We can have a perfect capsular access, central capsular access, as you can see here. And rest is same. Rest phaco is not a rocket science. Coming to this case wherein there were multiple incisions, and in this case we have not made a scleral kind of an incision. So here at this place, the incision has opened up because we have to traverse it. There was no place from where we can make a corneal incision. So in this case, as you have seen, that the opening was small. So I have used the iris was plugged over there, and with this plugging, there was no leak, and we could manage doing the emulsification and completing it. And at the end, we have given sutures. We have sutured tangentially to the wound, and we can also give one radial incision. If you have an option, then you can do intraoperative aberrometry and check the right power which can be implanted, and maybe you can use a toric IOL. Postoperatively, these RK incisions swell after the gentlest cataract surgery, inducing the central corneal flattening, resulting in hyperopia in immediate postoperative period. Patients will experience the fluctuations in their refractive state for many weeks after their cataract surgery, and some amount of initial hyperopia should not be a cause of concern in these patients, and sometimes we may have to wait up to 4 or 6 weeks or even 8 weeks. Depending on number of RK incisions, if the patient is still significantly hyperopic, even after 6 weeks, a second procedure can be performed. And in all these cases, I prefer a single focus lens implants. Aspheric IOLs may be a particularly good choice in these patients because of their significant corneal abrasion. So I prefer aspheric monofocal IOL instead of multifocal IOL, and I avoid cornea is irregular. It is difficult to achieve absolute or near emmetropy in these cases. Fluctuating refraction. Refraction can change from morning until evening, and there may be a progressive hyperopia can also induce, there can be change in the ciliary power over the period of time, and they may sometimes require keratoplasty. So with this, I thank you for your patient hearing.
Thank you, sir, for a wonderful presentation and an insight into the post-RK PHACOs. We have some time, we can take few questions or the practical tips from the expert panel. Dr. Suban sir, if you have a few comments on post-RK PHACO. Dr. Professor Tiwari sir. Dr. Nishlani sir, few comments and your practical tips for the PHACO beginners in such cases. Right. Then we, sir.
I think one is the point of concern is there is a risk of opening up of the incision which Dr. Purendra has dealt with very well, and maybe there is, at times you need to suture them, and keeping the parameters low can be of real help in this situation. The concern, I was just wondering that there is a chance that there is an initial hyperopia, and that should not be a concern because it will usually go in a few weeks' time. I am really not sure how much importance to be attached to this particular thing. Maybe other experts who have some experience in this particular situation may throw some light on this.
Giving this incision is one of the ideal things, like Dr. Purendra team very well explained it, because that takes away all the risk factors, the real incisions that we see in a little keratotomy. So that is a wonderful idea. Try to find out the location where the incisions are less, and you can get at least a good chunk, at least 2 millimeter chunk of the cornea clear, leaving aside the 2 radial incisions that will take care of not let this radial incision to get open. So this is again one of the things. Chamber is very deep. You can push the iris up so that you can get rid of deep anterior chamber, particularly in these cases. Coming to the IOL power calculation, every surgeon has got its own view of doing it, how to calculate and to reach to the emmetropia, but depending upon your practice and exercise and the data available and the software available on net in the different sites, they help you very much. And
this is how you can, I would say, plan your surgery for the next case. But the ideal, or I mean say, going through one rule that which definitely help you, that depending upon the axial length, you can keep on adding from 0.5 diopter to 2 diopters, particularly when you calculate out the different the emetropic power which you like to reach. These formula which are available, they are fantastic. I have been using these formula and practically achieving the emetropia. So these are the few things which I wanted to add on this one. Thank you.
Nowadays, with the help of all these new formulas and excellent surgical skills, the results in all these type of patients are very good. We are getting much better results than 10 years back we were doing a lot of RK patients. So nowadays we can even give confidence to our patients that you will not be end up with major refractive surprises. Even we are now using in lot many RK cases toric lenses also. And as far as we concerned about opening of riddle keratotomic cuts, sometimes during intraoperatively also we have to suture and then continue with the phacoemulsification. That also in one case it was very difficult for us to take the where that patient was having 36 cuts on cornea. So we did it. We took even incision also, but even in the cornea was given up. So in that case, we did intraoperatively, we sutured the flaps, and then we completed the phacoemulsification.
Thank you, sir, for the wonderful insights. We now move on to the next presentation by Dr. Vijay Nishlani, sir, and he shared his experience in phaco and posterior cataracts, one of the most intriguing phacoemulsification procedures. Dr. Vijay Nishlani, sir.
Yes, sir. So at the outset, I congratulate and give thanks to Gwalior Divisional Ophthalmic Society for inviting me and allowing me to share my ideas. How do I go ahead with the posterior polar cataract? I'll take you to a tour of few of the surgical clippings, and I must acknowledge the contribution of Dr. Mohanta, Dr. Ahmed, Dr. Suvira Jain in the form which I have taken from the YouTube, because they found the different ways of doing it. And with the time, I adopted a method which I call is a floating sign, and that gives me a confidence in dealing with this lemon particularly. We always say as the posterior polar cataract gives you around 25 to 30% of cases leading into a break in the posterior capsule. So how to go ahead safely with these posterior polar cataracts? Let us find out some of the points which we really need to definitely see in these cases. Never try to touch the plaque. This is what we have learned gradually from doing many of these cases. Plaque is firmly attached to the posterior capsule. So as soon as you take out the plaque, the posterior capsule is gone. A good hydrodelineation is a requirement. Let us see, this is the video which I was doing long back, around 15 years back. You can see there is a plaque here. I could see an opening as soon as I lifted the plaque, and there was an opening. So those points which I told you I learned in hand. What happens in a thick and a harder cataract, there is a loss of epinucleus, and that hard nucleus is always in touch with the posterior capsule. So never try to rotate the nucleus in those hard cataracts of posterior cataract. And this is a clipping from Dr. Mohanta. I took it from the YouTube. See, now that thick whole nucleus chunk is being moving or is being moved up. and see what happens. This is the area of the plaque, and this is an opening here. So as soon as you move it, the plaque opens. The posterior capsule is weak and degenerated in the area of the plaque. This is being shown by this one of the video. This is a posterior polar cataract of one of the little younger chap. As soon as you remove this plaque, you could see that this is a pouch kind of thing in the posterior capsule that extends into the vitreous cavity. So the posterior capsule at the level of plaque basically starts degenerating. So this is what we learned from the practice of doing these cases. Ultimately, optic capture kind of IOL was implanted in this case. Never ever polish in the zone of plaque because this plaque is weak. This is a video from YouTube. The surgeon is trying to polish that area, and you could see there is a small opening here. So good thing is that he has done a tamponade of that and can implant the IOL as a next step. Active pulling or pushing of the last plate of the cortex where the plaque is involved has to be avoided. So this is again one of the video. You can see that cortical material is being gradually from all the periphery has been pulled up, but the plaque is still there. The plaque is firmly attached. Whenever you try to pull this cortical material from the periphery and the plaque is get disturbed because which is firmly attached to the posterior capsule, you definitely find a surprise with the posterior capsular rent. You can see a small rent is already there. It is here. So whenever you try to pull the cortical material and the plaque is lying attached with the posterior capsule, this can give you the surprise. So these are the few pictures of the posterior polar cataract. What exactly you need to see, the size, the onion ring, the halos, the radial stripe that you can see, the fishtail sign which is going and dipping into the posterior capsule, vitreous cavity. Those are the cases where you should always be very cautious when you're going to deal such cases. The surgical planning, of course, I'll take you to a video that how I do it and how I adopted a method to get rid of this kind of posterior capsular rent. This is a surgical video that I do. After doing a capsular axis, always try to reach to the anterior level of the nucleus. So after you reach to the anterior level of the nucleus, then you do the hydrodelineation. This will give you a limit of the nucleus. So the aim has to be there that this nucleus has to be taken out without disturbing the cortical material and where the plaque is attached. So you can take an advantage of your second hand. Usually these cataracts are the soft cataracts, so they by the debulking method, they come out the whole of the nucleus which you have marked with the hydrodelineation, or you can take advantage of second instrument, the chopper or the hook or the Sinsky hook or something that way which is convenient in your hand. Take out full of the nucleus. Now what is left is the cortical material and the plaque in between. This is the irrigating port which is going behind the rim of anterior capsule. See what happens that when it goes, now it is in slow motion. When it goes behind the rim of the anterior capsule, the whole of the fluid wave which goes between the plaque and the posterior capsule, and since it is a passive kind of hydration, the plaque never breaks up or along with the posterior capsule. Rather, it gets detached from the posterior capsule. This is another case. Now the same thing is being done. The irrigating port is going behind the anterior capsule all around, the wave going between the posterior capsule and the plaque. Now gradually you see this cortical material and the plaque is gradually getting lifted up and this is what I call it a floating sign. So this is, I keep on doing, these cases with this method and never find any kind of surprise until unless there's any pre-existing posterior capsule right there that you could see on the slit lamp. Then of course you need to keep everything ready for the vitrectomy, anterior vitrectomy and all those things. Never ever try to polish that whatever is left out as a material over that posterior capsule. Just try to flush it off with all those things. So with this, I come to this kind of hypothesis that whenever the nucleus is there, you try to hydrodelineate this, increases the volume inside the capsular bag, and since the capsular bag is weak at the area of the plaque, it gives away. But what happens, looking to the figure number 2, the nucleus is now taken out, the bowel is little bit empty, this fluid goes from here behind the cortical material and takes this plaque away from the posterior capsule, and this is how I call it the floating sign. Once again, coming to the floating sign, you can see that the port going behind the rim of the anterior capsule, and it takes away the whole of the cortical material with the plaque and keeping the posterior capsule intact. So this is what I call it a floating sign, where you need to do this hydro procedure at the end, where the plaque and cortical material is there, very patiently and very gently, so that this whole bowl of cortical material with the plaque is lifted up, and this is what I call it the floating sign. Thank you.
Thank you, Dr. Nishwani sir, for the wonderful presentation and sharing insight into how to manage posterior polar cataract with the floating sign as you just beautifully described. We now move on to the next presentation on phaco emulsification in hard cataract. I'll request Dr. O.P. Agarwal sir to share his presentation. Dr. O.P. Agarwal sir. Since it's taking some time, we can take a couple of questions and or any practical tips and pearls from Dr. Suvin sir, Dr. Bhasin sir, Professor Tiwari sir, any of these tips on posterior polar cataracts and your experiences. Meanwhile, Dr. Agarwal is going to share his presentation. We can take a couple of questions.
As far as hydrodissection is concerned, I generally avoid that in posterior polars completely. And I do something called just a hydro-free dissection. We use a spatula and go all up to the equator and kind of free it. Because these posterior polar can be very unpredictable. So I would like to avoid hydrodissection as much as possible. And that is one of the ways. Of course, I mean, nothing is a sure shot.
I think it's very well covered. Hello.
Yes.
Yeah. So there's place only for hydrodelineation. Number 1. These cataracts are usually soft, and they are very easy to aspirate. So you really do not need much of the phaco power. And third is never try to remove the plaques. You can always do a yak capsulotomy on. This is what how I look at it.
Raman, can you help Dr. O.P. Agarwal sir for this presentation? Raman? Technical team from Enroad, can you help Dr. O.P. Agarwal sir for the presentation?
My screen is visible. Can you able to see my screen?
I think Dr. OP is doing the same mistake as Dr. Puren Basin did.
Okay, just let me know.
You just escape out of this window.
Okay.
You open up your PPT and then share the screen.
My PPT was
Sir, first stop sharing the screen.
Okay.
First stop sharing the screen.
Stop sharing. Stop sharing.
Yes. Now you open your PowerPoint presentation. Double click on your PowerPoint presentation to open it.
Now it is visible?
No, now you start sharing the screen.
Yes.
Sir, click on at the bottom side button, green color button, share screen.
Yes.
Yeah.
It is visible?
Yes.
Yeah.
Now you can go to the full
Go
screen.
to slideshow, sir.
So I'm going to talk about the hard cataract. I have not prepared any presentation. I am just going to talk about one of my video with very hard grade 6 cataracts. But what prerequisites we need to start with very hard cataracts? Nowadays, with the help of newer generation machines like Centurion, which giving active fluidics, operating this type of cataract is very easy for all of us. Though if we don't have good machines, even then we can do cataracts in very hard phaco in very hard cataracts. So I am going to demonstrate one very hard cataract. The prerequisites here is first we have to learn chopping. Chopping is very, very important to deal with very hard cataracts. 4 quadrants are split. All those techniques are not good if we are planning to operate very hard cataracts. So first, very important to learn chopping techniques. In very hard cataracts, I always advise that try to use stop and chop so that we can use minimal energy to emulsify the hard cataracts. Number 2, if we use machines like having active fluidics, I don't have any financial disclosure to make for this, but having this type of technology reduces the energy used during very hard cataract to minimal, and chances of corneal edema ASK post-operative is very minimal, very minimal. If I am going to operate this grade 6 cataract, you can see the total CD will be very less as compared to we are operating with any other machines not having active fluidics. So first, very important is divide this very hard bulky nucleus in multiple small pieces. The second important is we have to divide this nucleus, the small nuclear fragments completely, because the chances of posterior plate attached with each and every nuclear fragment is very high. So we have to, even sometimes we have to rotate it twice or thrice so that each and every fragment is divided 100%, because even a small fiber attached that we can deal with our experience, but that may sometimes give that 2 of hard nucleus fragments can come in the interior chamber, and then that can give a lot of trouble during emulsification. So first and most important is to divide it. Just hold it and divide it completely. 100% fiber should be separated. Try to separate as much as possible. I always prefer to separate the this leathery fibers 100%. So there are multiple, more than 6 to 8 pieces are there of this hard cataract. This I'm just doing just to demonstrate how we can deal with hard cataracts with active fluidics. That's why this surgery is shown in very high magnification. But you can see each and every detail in this video. I always give name of this active fluidics as like that we are operating, we are doing as we run, we drive a car in.
So your presentation is not visible, Dr. Begwal sir.
Visible?
No,
Not
sir.
visible?
What we see is just one slide, the lower and the higher IOP. The videos are not showing up.
Oh. Video is not visible. I'm sorry. I'm sorry. I was,
you will again have to stop sharing.
Video.
No, no, you have to click on the video. Click on the video lower IP. That's the object. You have to click on that video, sir. Video lower IP.
Yes.
Now it is visible?
Yes, sir.
So again I have to start.
Yeah.
So this is very hard grade 6 that I'm very sorry. Sorry. You might have interrupted me quite 3 minutes before. So just to make a small central well in the hard nucleus and then to chop multiple small nuclear fragments. With this active fluidics, we can work with very high vacuum up to 600, 700. You can see here it is I am working on 650 vacuum with minimal power we are using. So whatever I have discussed, that first important to deal with hard cataract is to divide the nucleus in multiple small pieces, multiple, more than 6 if possible. The second thing important is to divide the nuclear fragments completely. You can see how I am trying to separate the leathery fibers of this hard cataract. This is how each and every fragment should be divided first before starting emulsifying the these small nuclear fragments. Here, this type of technology helps a lot to reduce the required energy as well as fluidics will help us to emulsify these fragments very fast. Here I am working with vacuum 650 to 700. I always talk about this technology of active fluidics like we are driving a car with cruise support. Just keep the phaco handpiece in central pupillary area, press the foot pedal, and each and every nuclear fragment will come and automatically, it looks that automatically we can emulsify the fragments. So operating hard cataract to me I feel is much more easier and much better than operating very soft cataract. Even you can see the I'm going to emulsify the last fragment and the vacuum is same. I'm not reducing the vacuum. The power is 70, aspiration flow rate is 30, and the total energy used even with this hard cataract is hardly 14, 15 CDE. This is the last segment and the vacuum is same 600. There will be no surge. So hard cataracts to me is easier to operate with the latest technology. Thank you very much.
Thank you, sir, for the wonderful presentation and making look hard cataracts very soft and easy to handle. We now move on to the next presentation by Dr. Prajakta. She'll be talking on phaco in small pupil. Dr. Prajakta, please start sharing your screen. Yes, your screen is visible.
It's visible, sir? Yeah, go to slideshow, ma'am.
Yeah.
Yeah, perfectly coming.
You can start first.
Good evening, everyone. I thank the Gwalior Divisional Ophthalmic Society for inviting me for the presentation. I'll be speaking on phacoemulsification in small pupil. And large pupils make good surgeons great, and small pupils make good surgeons anxious. This statement was given by Eric, Dr. Eric from New York, and it's absolutely stands true, like especially for new surgeons who are doing, especially after residency, when suddenly you encounter a small pupil, you really don't know what you are into as when you are a single surgeon in any hospital. So I'll be speaking on the following headings. What are the challenges which are faced? What are the high-risk patients which have small pupil? The medical and surgical strategies and the case studies. The challenges faced will be because of a small pupil, there will be eventually small rhexis, there will be iris chafing, sphincter tear, iridodialysis, iris prolapse. The maneuvering of the lens will become difficult. There will be retained small particles of the nucleus behind the iris. There might also be retained cortex in that particular zone. Then IOL placement will become difficult. Mostly the IOL might get placed inside in the sulcus. Then intraoperative floppy iris syndrome is another issue in which there is billowing of the iris, there is flaccid iris, and there is quite often prolapse of the iris through the incision side, which eventually leads to increased postoperative inflammation, corneal edema, and cystoid macular edema. So which are the high-risk patients which have small pupil? These are the patients who are on long-term topical miotics like pilocarpine, patients with posterior synecdoche, diabetic patients, pseudo-exfoliation syndrome, then post-uveitic patients, patients who are on alpha blockers. And the medical strategies which are employed are, first of all, we use mydriatics we start with mydriatics for any patient. It might be used with eye drops, or it might be intracameral. So mydriatics in the form of tropicamide or phenylephrine combinations, which are routinely used, like 1% or 0.8% of tropicamide and 2.5% to 5% of phenylephrine. Then cotton pledgets dipped in mydriatic solutions can also be placed in the inferior fornix. There are studies which have shown that NaCID eye drops, especially flurbiprofen 0.03% and ketorolac 0.4%, they are often shown to have a sustained mydriasis during surgery. They may not add to the mydriasis, but they are known to give a sustained mydriasis. Then intracameral solutions like epi-sugarcane, midraine, and omidria have been experimented and shown to give a good result in small pupil. The omidria is basically a combination of phenylephrine and ketorolac. So ketorolac is known to decrease the prostaglandin secretion by suppressing the cyclooxygenase enzymes, and which indirectly decreases the meiosis. And viscomydriasis is used, in which actually the viscoelastics are placed in a donut shape. The outer surface of the donut is basically the cohesive viscoelastic, which is covering the iris surface so that it doesn't cause billowing. And the central part is where the high shearing forces of phacoemulsification are going to take place. You have a dispersive viscoelastic placed, and the dispersive viscoelastic also coats over the cohesive viscoelastic so that it doesn't get removed easily. The surgical strategies employed are synecholysis, pupil stretching, sphincterotomies, and pupil expansion devices. In synecholysis, basically you are decreasing the contraction forces which are caused by removing the posterior synecdoche and also removing the pupillary membranes which are responsible for it. In pupillary stretching technique, these are the different instruments which can be used to stretch the pupil. Pupillary stretching is usually done in a single meridian, and if still the pupil doesn't dilate, it is done in the opposite meridian as well. So from 4 millimeter to 5.5 millimeter can be done. And in this, this is basically contraindicated in IS, but otherwise for rigid pupils, this maneuver is definitely required. Now the basic mechanism is that it causes microsphincterotomies, which are responsible for increase in the size of the pupil. This is a Wheeler's pupil dilator. With this is a 4-point dilator, and dilates the pupil in a uniform fashion. and so that there is no irregular dilatation of the pupil at the end of the surgery. The sphincterotomies are, then coming to sphincterotomy, these are basically done not beyond the collaret, so that so that in the post-operative period you get a small pupil eventually. If the incision goes beyond the collaret, then generally the pupil stays dilated in the post-operative period. Coming to pupil expansion devices, the most commonly used is iris hook. It's a flexible J-shaped iris retractor made of nylon, available in 2 sizes. And there is a specific relationship of the silicone sleeve attached to it with the tip of the iris hook. And it gives a clue to the orientation of the tip of the iris hook. Then the entry point is used at the posterior limbus. These are the pictures showing that the 4 iris hooks applied in the first picture, they are equidistant to each other. And in the second picture, it is shown that it is also used to hold the capsular margin if required in few cases. And the third picture shows how subincisional use of the 5th iris hook has been done, and it's very important that it is taken at the posterior side of the limbus. In the last picture, there are 3 types in which one clear corneal incision is shown. If there is a clear corneal incision, then the way the iris behaves is different than when it is placed posteriorly. So otherwise, if it is more posterior, then it gives rise to crumbling of the iris. So it is important that you put the iris hook in the iris plane, pupillary plane. The difficulties in iris hook are that if there is a pterygium or if there is a bleb, then there is a problem of placing the iris hook. Subconjunctival hemorrhage and conjunctival ballooning can also take place. And if there is a tight palpebral fissure, then the other end of the iris hook might get pressed upon the wire speculum or the eyelid and causing dislodgement of the iris hook. Then APX is another expansion device which is available. In this, instead of 4 incisions as in iris hook, 2 incisions are made. The incisions are 1 millimeter in size. As in iris hook, the incision size may be around 0.5 mm. Here the incision size required is 1 mm, but only 2 incision sites are made. And when the pilot of this instrument goes inside the anterior chamber, only then the forceps are released. This gives rise to a trapezoidal opening or a quadrangular opening. Quadrangular opening occurs when the incision sites are 180 degrees apart, and trapezoidal opening occurs when they are unequal in distance. And it may give rise to microsphincterotomies, and a few cases have shown to give rise to hyphema. Malusian ring it has come in 2 versions. The latest version is the Malusian ring 2, in which they have increased the scroll depth, knowing that the iris might get edematous eventually after phacoemulsification. So dislodgement of this ring becomes easier with Malusian ring 2. And it also, the inserter which is required, inserter which is available it goes through the size of 2 mm as we are progressing towards MICS surgeries. This is a picture showing how the Malusian ring manipulator is used to place the Malusian ring. There are various special situations in which Malusian ring has been experimented, including femtosecond laser-assisted cataract surgery. Then Agarwal's modification was that a suture was passed through the leading coil, so that if there is a case of suspected PCR, then it's easier to remove the ring. For ectopic pupil as well, this ring has been combined with iris hook and is used in such cases. In patients with ectopia, lentis, zonular instability, and triple procedures too, this ring has been experimented and found to be successful. These are the other expansion devices, OSS iris expander, coming in a square-shaped device. This also requires an inserter. This is an eye ring, which also requires an inserter. This is how it is used. This gives rise to a dilatation of 6.3 mm, and the incision size is around 2.3 or 2.5 mm incision is required for inserter. Now, this is the expand iris expander. This also requires an inserter and gives rise to an octagonal opening. It's made up of nitinol wire. Then Dr. Bhattacharya is here and he'll be speaking about this topic. But I found this to be an excellent device, can be used in MICS surgeries because it doesn't require an inserter, goes through a 0.9 mm incision, and very thin. The thickness is so low that it can be easily used in shallow ACs. Then these are the other expanders like Greether 2000 and Watcher pupil dilator. These are the semi-circular rings. Perfect pupil. All these are semicircular rings, and it can be used in parts where, like coloboma, where there is iris defect, in which the complete surface of the iris need not be covered. The case studies which I came across, where this case study. Sorry.
Yeah, can we summarize, please?
Yes, sir. So there's a comparison between iris hooks, Watcher ring, velar dilator, and pupillary stretching, in which iris hooks and Watcher ring require longer surgical time as compared to the pupillary stretching. Then there is the high vertical thickness and high rigidity gives rise to endothelial touch. Then the stress over the pupil was maximum with APX pupil expander. The pupil expansion devices also help in inhibiting the iris billowing. The Malyudian ring has shown certain complications, but it is known to cause less endothelial cell loss as compared to iris stretching. It is also faster as compared to the iris hooks. And coming to BAX ring, it has low vertical height and good specific gravity. So it also reduces trauma to the endothelium. There are other studies which have shown that use of atopin 1 day prior to the surgery is not recommended because it decreases the pupillary size. And also use of anti-inflammatory is recommended 1 day prior or 3 days prior so that it helps in maintenance of the intraoperative mydriasis. The pupil of 7 millimeters or smaller has the risk of IFIS regardless of alpha-1 blockers. And this is a study in which omidria has been used, and they have also observed that 4% of patients who received omidria had a pupil diameter of less than 6 millimeters after cortical cleanup. This is a take-home message that if there is a small pupil, you start it with mydriatics or viscodilatation. If it is adequate, proceed the surgery. If it is not adequate, analyze whether there are any additions, whether a pupillary stretching is required. And if there are no additions, use an expansion device. If there are additions, remove the additions, use pupillary stretching. Again, try with mydriatics and viscodilatation. And if not possible still, then again, you can use an expansion device and proceed with surgery. Thank you.
Thank you, Dr. Bhattacharya, for a wonderful presentation and insight into managing small people. Now I'd like to welcome the entrepreneur, the one who has innovated and had a out-of-box thinking in management of small people with this BX device, Dr. Suvan Bhattacharya, sir. Dr. Suvan?
Yeah. You can see my screen now?
Yes, yes.
Oh, okay. Thank you, Gwalior Division of Ophthalmic Society and Dr. Manav for this very kind invitation. Let me see. Yeah. Am I on full screen now? Can I just
yes.
To my
slide?
Yes. Yeah. Yeah. So now, and thank you, Colonel Prajakta, for that wonderful overview of a small pupil that sets up the stage so nicely for me. Just, to add to that first slide of yours where you said it makes great surgeons anxious, but it shouldn't do that for a para jumper. For a para jumper, small people should be a piece of cake, correct? So anyway, it's nice to be among friends. Purendra over here is a wonderful friend of mine, and I think he's done more live surgery for BX than I have done. So Gwalior already has, and Dr. Shukla showed a wonderful BX pupil expander surgery. I have a financial disclosure in terms of my patent with the BX pupil expander and my holding in MedInvent devices. And I do thankfully acknowledge the contribution of Neto Rizzotelli, Dr. Deepak Megur, and Dr. Ayan Mahanta for the videos that they have lent for this presentation. So we'll be talking about the BX pupil expander, pearls and pitfalls. Now, why did I choose this topic when Dr. Manav invited me? Way back in 2016, I received a WhatsApp message from a very well-known surgeon. He said 2 cases done, one before and one after seeing the video. Watching the video certainly makes a huge difference. The second case today perfectly, the hexagonal pupil, intra-op and round post-op. Congratulations, Suvin. That kind of spurred me on to make some pearls, and so that we can guide. Every new thing requires a set of instructions and devices. So I thought that would be useful for all users down the line. And over the years, this is over the last 4 years, probably we've been collecting these small pearls, and I shall be sharing them in the next 50 minutes with you. I'll be happy to answer any questions after that. So what I believe is that BX is in a timely invention about what the surgeons want and need. It's simple, safe, and easy to use, and we have very happy users. I also believe that the BHEX pupil has a redefined pupil expansion. Now, why I believe that is that I did have a few awards to start with before. I had the CS Rashmi Award and other awards, but then most of my awards have come after the BHEX. So that kind of is a testimony to the fact that the pupil expansion has been redefined by the BHEX. Now, to compare with the Malyugin ring, Malyugin Boris is a great friend, and this is a wonderful device. The only hitch was that it was a 2-plane design, and this scroll, it catches the incision lip and the inserter. So that was a big hurdle in our surgery. So we came with the BHEX, which is a single planar device, uniplanar device. It has got stronger flanges and thin flexible notches. It's an hexagon with flanges and notches. And we've got tabs for holding. And of course, we recommend only the 23 gauge forceps. Now, no manipulators, no Sinskiotes. They don't work very well, and they lead to more complications. So let's look at this animation. So it's a uniplanar device, 75 microns in thickness and 7.5 millimeter circumcircle, 6 notches, 6 flanges, and it comes in a housing which allows you to take the device sterile to the incision. Just hold it with the forceps and lead it into the eye, and then tuck all 3 flanges under direct visualization. And you have a wonderful hexagonal pupil which serves the purpose of pupil dilatation. It's a uniplanar device where the iris actually bends at the notches and the device remains in a single plane. And removal of a pupil expander has never been so easy. You can just walk out through a main incision, and the best part is you can even remove it through a side port 1 millimeter incision. That no device can do. So the radically different concept over here, or the inventive step, is that the device is in a single plane, unlike the other devices, and the iris is bent at the notches. And as we know, the iris can be bent without any harm. It's reversible completely. So the first pearl is we should use the BHEX 23 gauge forceps. As you can see, it's got a curved stock. I don't know why this is not moving. This video should be moving. Okay, it's got a curved stock, set jaws, and the jaws open perpendicular to the plane of the squeeze handle. Should look for the, I'm trying to use there have been some fake BHEX forceps, which I would like to caution you about. Now, the next pearl is where and how much of viscoelastic do you use, whether it's iris or pupil expanders, the principles are the same. Now, there is a tendency for us to initially inflate the anterior chamber and inject a lot of viscoelastic. In the process, what we do is we end up flattening the iris onto the lens capsule, and that leaves no space for the device, and that becomes difficult for us. So it would be ideal to inject viscoelastic under the pupil margin and lift it off a little bit. So you lift up the pupil margin and you have that kind of space over there for the device. You keep the anterior chamber shallow, unfilled with viscoelastic. Iris bowing will help in the hooking of the iris or tucking of the flanges. Overfilling will push the iris against lens capsule, and we inject viscoelastic under the pupil margin to create that space for the device. So just recapping the last 2 pearls, we must watch videos before we use the first few uses, and we must keep the anterior chamber underfit and inject viscoelastic under the pupil margin. So this is how we do that. Inject a little viscoelastic just centrally enough to avoid any endothelial touch, and then we inject viscoelastic under the pupil margin so that we lift off that pupil margin, and that facilitates the tucking of the flanges. Thereafter, the job becomes a lot easier. In 2005, Chang and Campbell told us about the IFIS pupil. They said that unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So there is an element of elasticity in the IFIS pupil, which is very different from the rigid or fibrotic pupil. So the elastic pupil is like a rubber band. It can be stretched, and any expander would work. Whereas the rigid or fibrous pupil is non-elastic, and it's not stretchable. It can be torn. So it requires a strong and bulky expander to be used to tear the fibrotic ring. So the choice of the pupil expander will depend upon how you wish to tear the rigid or non-elastic pupil. So with 2 Coughlin hooks, you can have a controlled tear, you have a round pupil, and you can use the BX, which is 75 microns, as thin as the hair, and it occupies less space in the antechamber. It's very easy for you to move your instruments around. If you want to do it with the pupil expander itself, then well, you'll have poor control and lead to asymmetric tears. The Mulligan ring, the APX, and the I ring would fall in that category. These are bulkier devices that occupy most space in the antechamber, which are obstructions to your movement of instruments in the antechamber. So we need to start checking with the elasticity of the pupil before we start the case. As soon as we make the paracentesis, inject a bit of BSS into the side pupil, and that momentary expansion of the pupil suggests that it's an expansile pupil. Whereas with a rigid pupil, when you inject that BSS to the side port, there is hardly any expansion of the pupil, and that tells you that it's a fibrotic pupil. And this pupil needs to be stretched. Whatever means you use is up to you. The device itself or 2 Coughlin hooks, I would much prefer to have the Coughlin hooks. Do it before I use the VHEX expander. And then you have, that's the pre and the post stretch. That gives good enough for you to now use a BHEX. So what matters most is the elasticity of the pupil and not the size. I think that's a clear pearl that I would like to convey. And the next video will beautifully tell you how that is important. This is a video by Dr. Neto Rosatelli from Brazil, a good friend of mine, and has been using a lot of BX, and he's a wonderful surgeon. Let's take a look at the video. Now that's a rigid pupil, but he's just removed that small pupillary membrane. And look at that small pupil, it's just less than 2 millimeters probably. You would never imagine that you'd be able to use a BX over there, but look at that pupil is elastic. So he's using a bimanual technique because otherwise the excursion of the flanges, I mean, you won't be able to cover that. So uses an iris hook on one hand, and yet you see that pupil was elastic enough to allow the BX to be used. So the size of the pupil did not matter, it's the elasticity of the pupil, and that's a very important message I would like to convey. So if the pupil is rigid and less than 4 millimeters, please stretch it bimanually before using the BX. The BX is not a strong muscular device like the Mulligan or APX or the I ring. So it's a rather delicate device, and you need to kind of set up the stage for it to work well. There's another question which we often ask is, how big do you want the pupil to be? Now, aren't we all skilled to perform phaco with a 5.5 millimeter pupil, which will not get smaller? If you have the assurance that it will not get smaller, all of us are happy doing that surgery. So the BX gives you an assured 5.5 millimeter pupil, and that's all you require even for the hardest cataract. So the next video will show you a video by Dr. Deepak Meghur to show you how this is a eye with a pseudo exfoliation. Video is not moving, and I'll just exit the presentation and come back. Yeah, so this is a rigid pupil with pseudo exfoliation and a hard cataract, and you can see that once the pupil is stretched, it allows the BX to be used, and there the cutting of the flanges is so easy. That's a pretty hard cataract by any standard, and you can see a 5.5 millimeter pupil provided by the BX is more than adequate for this hard cataract, and eye implantation followed by the removal of the ring. That's always a piece of cake. Now, if you have intraoperative miosis after your capsular excess, what you need is a very thin device that can be held and guided into the space between the capsular rim and the iris in a controlled manner without engaging the capsular excess margin. Now, when you use a Mulligan ring, it's used with an injector, it's more remotely controlled, and it's more likely to engage the capsular excess because you don't have control at the point where it is engaging the pupil margin. The BX is held with a 23 gauge forceps and is uniplanar with its open notches. It does not engage the capsular excess and provides instant confirmation that you have not engaged the capsular excess. Let's see this case of intraoperative miosis by Dr. Meghur. As he's starting his phaco, the pupil comes down on him. So inject a little viscoelastic under the pupil margin, lift it off, and then start tucking those flanges, alternate flanges, and you have, it gives you instant, as you take that pupil expander to the side, it gives you instant confirmation that you have cleared that capsular margin and have not engaged it. That's very useful with the BX. You're absolutely sure as you tuck each flange that you've not engaged the capsular excess margin. Fixation of the globe with the side port instrument helps in manipulations, And in deep set eyes, sometimes it will be very difficult to use the 23 gauge forceps. So you can rotate that eye a little bit, and the side ports will become more accessible. The bridge of the nose doesn't come in the way, or the high forehead doesn't come in the way. So this is again another case where Dr. Deepak Megur, she'll show you a side port instrument. I also pretty much use the same side port instrument. It kind of seals that, locks that instrument, the side port, and you get pretty good control on the eye. With practice, actually, you use this lesser and lesser because you learn those small nuances, delicate nuances, and you don't need that side port instrument. But initially, it would be very helpful. If you have a shallow anterior chamber, what do you need? A thin device. So the BX is 75 microns, so 0.075 millimeters throughout. The corners of a malignant ring are 0.9 millimeters. So, and as we all know, the mid-peripheral AC is much shallower than the central anterior chamber. So, and these corners actually rest at the mid-peripheral AC, and sometimes they are on the surface of the iris, and that could be very dangerous. So this is a 70-year-old lady with a very shallow anterior chamber, as you can see over here. And the BX was very handy over here, tucking, because the 23 gauge forceps and the BX put together is still 0.6 millimeters. And so that's pretty easy to work in a very shallow anterior chamber. It allows you full control as you're tucking those flanges, and this was complicated with the subluxation, so a CTR was used. So you can get away with a BX in a very shallow anterior chamber pretty easily. A pearl which I would like to offer is do not dislodge the BX or any pupil expander for the matter when you use it, either during your phaco emulsification or during IOL implantation. More often than not, it's that stage at which you can dislodge it. If you dislodge it into the anterior chamber, it's not such a big issue, but if you dislodge it into the capsular bag, it can become a little bit of a pain. So chop the nucleus into small fragments, attempt in the bag delivery of the trailing haptic of the IOL. These two are golden words, and if the trailing haptic is not delivered in the bag, pushing it against the pupil margin might dislodge the BX. Remember that, because the BX is just anchored, is kind of just hanging on the pupil margin. Now, if the trailing haptic is not delivered in the bag, there's a problem. You push or pull the outer edge of the trailing haptic in the IOL plane. So what happens is basically flexion of the opposite or the leading haptic optic junction against the equator of the bag creates room for the trailing haptic to negotiate without contacting the pupil margin. So I'll show you a couple of videos. Now this is where the trailing haptic clears the pupil margin and goes in, so no issue at all. That would be the ideal, but sometimes we can't do that. So when we can't do that, again I'll let it exit. This video is not playing on its own, so. Sorry. Okay, this video is not playing, but anyway, the principle remains that we need to push that trailing haptic. I'm sorry about the video. I'll try to show it later if I can. Now, this is a situation where the BX got dislodged by Dr. Ayan Mahanto. As he was tucking the IOL into the bag, the BX went into the bag along with the IOL. If it does happen, there is no reason to panic. Just lift that IOL a little bit, and you can see any part of the BX, hook it with any Kuglen hook or any device, and bring it into the anterior chamber and just cut it and pull it out. It's so thin, it's very easy to bring it out. Don't try to bring it out intact, because then it will kind of engage with some part of the IOL and draw it out. So that's very easy. Now, removal of, let's look at the video on the left of your screen. That's removal through the main incision. Just disengage that flange and advance it a little centrally, and you can untuck all the other flanges, and the trailing flanges actually untuck spontaneously, and you have a wonderful round pupil at the end of the surgery. And now you'd like to look at the right video on the right. This is removal through the side port incision. You hold that flange, advance it a little towards the center so that you untuck that flange and the next flange alongside, and then we just draw that out of the side port 1 millimeter incision, and that no pupil expansion device can do. In a tight IFIS situation where your iris is prolapsing through all ports, this would be very handy, and you can find it very useful. So what would be your pupil expander would depend very much on what your choices are. If you want it to be easy to insert and engage through a small incision, expand an elastic pupil, and hold the pupil expanded and be unobtrusive, BX can do it all. But so if you want to tear a fibrotic pupil, the pupil expander will have to be bulky and strong, like I said. You can do this very well with 2 Coughlin hooks, and then the BX can do the rest. So these are a few publications that we have in JCRS and IJO. This one is by Dr. Devdulal Chakraborty in vitreoretinal surgery is used, so that can be very useful in if you have, though most vitreoretinal surgeons are very comfortable with pretty small pupils with the current viewing systems, but in tight situations, especially if you're combining with the phaco, it would be useful to use a BX. Some testimonials, some rich words of appreciation by some leading figures who have used the device. Thanks to them. And these are from India. I'm very thankful to my colleagues in India who have been very supportive and provided us with most of these pearls have come from our friends over here. And these are invaluable and in the early years. And these are the ones which we are carrying. And I keep adding these pearls as I get inputs from them. You're free to offer any suggestions that you have, and I'll be happy to incorporate them. And it's a learning process, and it's always continuous, and we're happy to learn. And these personal messages from my friends, it's been very gratifying. These are all WhatsApp messages which I keep getting once in a week or once in 2-3 weeks. And these are really, they make my day every time I get such a message. I'd encourage all of you to take a look at this particular write-up from me. This is 10 tips on phaco emulsification, available at eophtha.com. And thank you once again, Gwalior Division of Ophthalmology Society, for this kind invitation. I'll be happy to take questions.
Thank you, Dr. Subhasan Bhattacharya, sir, for a wonderful insight into a very innovative, very useful device, probably one of its kind that we've seen over the past couple of years. Very out of the box thinking, and thank you for taking out time and sharing this device with us and having to use it much more frequently than we probably would be using it till now. Thank you once again, sir, for the...
Thank you. Thank you for the kind invitation.
Can I?
Any questions?
Can I, Dr. Manav, say something?
Sir, please.
Can I say something, Dr. Manav?
Kindly, sir, kindly.
Yeah, if you permit me. So, Suvin, I really appreciate your presentation and your innovative, everything so nicely, so beautifully, and in variety of cases. I have been using it for last almost 4 years, 3 or 4 years now. And I find it to be a very useful device in all variety of cases, and with all kind of cataracts, small shallow anterior chamber and intumescent cataract and brown cataract and all. And I find it to be quite useful. And the good part is that it is a very thin and less traumatic to the tissue, iris and a corneal endothelium. And the removal is also easy as compared to the other devices. Earlier, I was using Malukin ring and Oasis ring also I have used, and they are definitely stronger, but they are bulkier as well. So that was the downside of those rings. They were useful, but the removal, I still remember I had a traumatized iris with the Oasis ring once, and I had iris, this thing, root of iris was damaged with it, got damaged with it, then I had to repair it at the end. So all these things are there, but I really appreciate this thing. And we can use it, and I will definitely recommend others also to start using it if they find it any place in their phaco practice.
Thank you, Purinder. Thank you very much for your kind words. And I know I've actually been getting calls time and again. Dr. Purindra is doing a live surgery. Wahan pe Cochin mein, and I keep getting those calls. So very kind of you, and you are a good surgeon and a very nice friend. So I'm really thankful to all my colleagues all over the country who've been using this device and supporting us. And actually, it's a learning process, and we learn from each other every day.
I would like to add one comment. I have shifted 100% to the BX ring now. I was using the iris and others, and I'm pretty happy with it. I've got a series of around more than 100 cases wherein I've used the BX ring, and it actually comes out of the side port. It comes out so easily. There's hardly any flaps or any kind of OBD coming out. So yes, it's fantastic, sir. I'm really.
Yes, Dr. Shukla, I saw that video of yours. That was wonderful. Very clean surgery. Purendra, just address that question of yours. I mean, just the mechanics part where the iris getting caught. I mean, it's just a little bit of an engineering thing. With the Mulligan ring, what happens? The scrolls are there. So the scrolls are, they got, let's say it's got a gap. So it acts like a torsion spring as well as a compression spring. So when the arms come together or they move apart, the gap between in the scrolls kind of becomes smaller and enlarges. And that is very unpredictable. So when you are, kind of removing it, if it catches the iris, you don't know what to do now. If it's just caught the pupil margin, so that's there in my publication, the JCRS, it's there and that's been cited many times. So that's the mechanics because it acts as a compression spring as well as a torsion spring. That kind of, it's very unpredictable, that gap. Otherwise, Mulligan ring, I think Mulligan ring has served its purpose very well for us, and we're really thankful to Boris for the wonderful invitation.
That's true. Thank you.
I'll be happy to answer any more questions. Anybody?
The forceps also design is very good, and serrated forceps, I think that I'm using at other places also,
Yeah, Manav will agree with me. That's my vitreoretinal training which has come to use. So I don't do any vitreoretinal surgery now, but at least I put that to cataracts. See, what happens is the ergonomics are very different. VR surgery, our forceps are very different, and here to have the jaws open at an angle perpendicular to the squeeze handle was very important, and have it shortened, because I have damaged quite a few of my VR forceps doing this because the stock is so long. The VR forceps are for doing retinal surgery. So then I had to design this, and then we got it short to about 15 millimeters. That's an ideal length.
Wonderful. Innovator, I should say. Innovator, and
training at various places has helped.
What is new in your armamentarium now after this?
Lots of things are new, but nothing is really taking good shape. So actually, from the past experience, I know that unless I have something which is very valuable and it will really make sense, because the process of inventing and bringing a device to the market and making it commercially available is a very long, lengthy exercise, and it takes a lot of, and actually for me, this lockdown has been very valuable. I've been busier than my regular days, and 6-7 months I spent very usefully, and that's why you're getting a lot of carpet bombing of your mails and WhatsApp messages. I'm finding time now. So sorry for that, but the whole idea is to offer the pearls so that people can learn and use the device properly.
Nice. Thank you.
Thank you.
Thank you, Dr. Srivan sir, for a wonderful
insight. Thank you, Manav.
Yeah, it was great pleasure and a wonderful option to have you here and share your thoughts on this. Any expert comments from the expert panelists? I'll invite Dr. Vijay Nishlani sir, Professor Tiwari sir, Dr. O.P. Agarwal sir to share your insights, a few tips for the PHACO beginners or the PHACO neophytes.
For the beginners, I think the topic has been very well covered by the initial speakers. I think SICS is an opportunity where we should learn using both the hands. We should also learn using all the 4 limbs and brain and synchronize everything. That is for the beginners. You must learn using left side port also. Even in SICS, you can make a left side port and try to, practice using your left hand. CCC definitely helps you. You can always do it in the SICS. Of course, you must make a larger axis for SICS. Nuclear rotation also you learn while doing SICS. When you start learning, I personally observed that there are 3 blocks. Dr. Manav, am I audible?
Sir, you very much. Kindly continue, sir. Hello? You may continue, sir.
Dr. Tiwari is now...
Has he muted, sir?
Mano,
so you have muted yourself. Unmute.
Mano, just unmute Dr. US Tiwari.
Ento team, kindly unmute Dr. Professor Tiwari, sir.
Yes.
Hello. Right. Am I audible now?
Now you're audible, sir.
Hello.
Yes, sir, you are audible.
Good. I was talking of blocks while performing CCC, while learning the phaco emulsification. The first was the mental block. You are afraid of several complications such as nucleus drop and the corneal burn while performing phaco. So that is a mental block. You need to, get onto. You need to watch videos. You need to interact with the experienced as well as inexperienced surgeons both. That gives you a lot of, stimulus or an impetus. The second is the CCC block, which you always learn through your SICS or ECCE. And the third is the nucleus management block. I think if you can crack the nucleus, then you can always consume even the hardest nucleus, no problems. So I think this should be done in a phased manner and leave those complicated cases like a small pupil, like a very hard cataract for the experts in the initial phase. And then gradually as you become experienced, you can always, perform these procedures, this type of the difficult cases also. As far as the small pupil, I think Dr. Bhattacharya has made a very important point. It is the elasticity thing. I think that is the key factor. If you can do stretched pupiloplasty as the first procedure, I think Prajakta also mentioned it, that stretched pupiloplasty is something which will work, especially in a situation like rigid pupil, because of I've seen many cases of the pseudo-exfoliation while I was in Madurai for my training, and they do stretched pupiloplasty in a number of cases. The one which was suggested by Dr. Surin Bhattacharya sounds logical as innovative. I think one must always try in a small pupil situation. So that is how I look at it. Thank you, dear.
Any questions from the panelists? Any expert comments? If there are none, we move on to the next two presentations by the Entod pharmaceutical, one which will be presented by Dr. Rajan Gupta, and he'll share his experiences with phenylephrine assisted cataract surgery, or as they call it, PACS. Dr. Rajan Gupta?
Yeah, good evening, dear friends. Am I audible, sir?
Yeah, you are audible, Dr. Rajan.
I'm highly thankful to Gwalior Division of Ophthalmology Society for giving me opportunity to share my views on phenylephrine assisted cataract surgery. There is, for the financial disclosure, I have no financial interest in this product, but I found it a wonderful product during my cataract surgery. So mydriasis, a good mydriasis is a good concern for all of the cataract surgeons. So it is the foremost concern amongst all the surgeons. So cataract surgery IOL implantation requires adequate pupillary dilatation and stable mydriasis. So it is rated one of the most important factors during the intraocular surgery. So rapid onset of mydriasis is also considered a key factor in the basic cataract OPDs. Various complications of intraoperative myosis, when it occurs during the cataract surgery, can jeopardize the quality of the IOL implantation, which can further cause the complications, which is because of the iris trauma and the posterior capsular rupture with or without vitreous loss. Intraoperative complications, which they prolong the surgery, increase as for endophthalmitis and macular edema because of the iris trauma and the increased surgical manipulation. So the importance of stable mydriasis is the most important factor in the cataract surgery. It facilitates the surgical maneuvers such as the cortical cleaning, the PC polishing, capsular access, the IOL manipulation, the accurate position of the IOLs. So it mitigates the intraoperative complications, and it is more important to surgeons than the larger size of the dilatation. So first of all, we should know the anatomy of the pupil. It has two pupil in the iris. It has two types of muscle, the sphincter pupillae or the circular muscle, and the dilator pupillae or the radial muscles. So during the bright light, pupil reduces in size because circular muscles of the iris contract, and pupil open wide as the radial muscles of iris contract during the dim light. So the various mechanism of action of the different mediatic agents is there. So the sphincter pupillary or the circular muscle is supplied by the muscarinic receptors, and the radial muscle or the dilator pupillae is supplied by the alpha-1 receptors. So various mediatic agents like the tropicamide act it is a parasympathetic agent. It blocks the muscarinic receptors of the eye muscles. And the phenylephrine is a sympathomimetic agent. It stimulates the alpha-1 receptors, which dilates the pupil. And the xylocaine, the lidocaine is used as the local anesthetic, which inhibits the impulses of the neurons and paralyzes the eyeball parts. So traditional mediatic eye drops are the phenylephrine, the tropicamide, atropine, bromoatropine, and the cyclopentolate. It's a topical mediatic solution for the cataract surgeons. There is disadvantage of the topical mediatic eye drops that it has delayed onset of the mid-phases. It has limited bioavailability, and the multiple doses of eye drops are required to attain the mid-phases, which can damage the ocular surface and possibly they cause a superficial keratopathy. And inconsistent mid-phases, the intraoperative pupil masses may be there. And there is a negligible amount of the systemic absorption, which will lead to a little bit of rise in blood pressure. So is there an alternative to this topical mediatics? Yes. The intracameral injection of mediatics, it is the best alternative to the topical mediatics. So it has a prompt onset of the pupil dilatation. It has the stable mid-phases and improves the intraoperative condition during crucial steps such as the intraocular lens implantation. And it is very safe and effective alternatively, very less of systemic exposure and significantly less pain and sensation of pressure to the patient just before the eye insertions. So we can, in comparison to the topical mediatic, the 95% pupillary dilatation is achieved within a mean of 28.6 seconds after administration of intracameral injection of topical mediatics. The mean pupillary diameter was larger than 7 millimeters during entire surgical procedure, and intraoperative pupillary diameter remained stable in intracameral combination group, and there was a little bit decrease in the topical group of the pupillary size. So there is no clinically significant change in the pupillary diameter, which occurred in majority of intracameral combination group compared with the topical group. So mean time of pupillary dilatation estimated for intracameral is 28.6 seconds versus 20 minutes for the topical mediatics. So the product introduced by Antor Pharmaceutical Phenocaine Plus, I'll share you my personal video, which when I use the intracameral this Phenocaine Plus, you can see that I'm just starting the video. When I inject just 0.1 ml of intracameral Phenocaine Plus, see how fast the pupil dilates. It's in the darker pupil. You see, it takes hardly 15 to 20 seconds. It looks like a magic. The pupil starts dilating. Now it is in the lighter iris. You can see how much time. You can see the duration of the. These are there is no editing in this video. You can see hardly 15 to 20 seconds taken by the drug to act, and a good pupillary dilatation is achieved. So the overview of this Phenocaine Plus product, it has a composition tropicamide is 0.02% with a phenylephrine 0.31% and lidocaine is 1%. So it is used for the intraocular surgery, and just 0.2 ml is required intracameral, and side port or the main port you can use. I've used this drug along with I've used in hypermature cataracts as well, and there was no interaction with the blue red light for the staining of the capsule. And in the post-operative usage, there was no TAS or endophthalmitis associated with this drug, and all the corneas were clear and stable in the next day. And thank you, sir. Thanks for giving me the opportunity to share my opinion on Phenocaine Plus. Thank you, sir.
Thank you, Dr. Rajan, for a wonderful insight into Phenocaine Plus. I invite the faculty to share their experiences, if anyone has. Dr. Vijay Nishlani, sir, Dr. Bhasin, sir, Dr. Subhan Bhattacharya, sir, and Dr. O.P. Agarwal, sir, if they have any personal experience with this product.
I have used this product. This is an excellent product and gives an immediate mydriasis. Good, even if our patient is in OT, without putting any mediated drops, we can start doing surgery and we can use this intracameral phenocane. You will get excellent dilatation.
Sir.
Even sometimes earlier Dr. Suvin was sharing his video when the pupil got constricted during the surgery. It was fully dilated before start of the surgery. If you put the intracameral phenocane plus, the pupil may dilate in such cases. Because the pre-operative the pupil was fully dilated in that patient.
I want to know, Dr. Rajan, is there any adverse effect of this drug?
I've not noted any adverse effect with the drug because it's totally safe because we are using it intracameral only. So there is no systemic adoption of the drug, only topical, but I've not noticed any TAS or any related issues with this.
So we can also use in hypertensive patients?
Definitely, why not? It's very safe to use in hypertensive patients.
And for how long its effect lasts during surgery once we have introduced?
I've done surgery till half an hour once it is introduced, but there was no rebound meiosis in this patient. Even when you struck up in the patients, you can re-inject this phenocane plus.
Okay, so at a time, how much quantity we must inject initially?
Initially, we are using 0.1 to 0.2 ml of this.
And if required, when we can inject again?
Yeah, you can re-inject.
Okay.
Earlier, when I made the trial of this drug, I made trial only in the patients when I was struck up because 1 year back the drug was not approved at all. So I used it when I struck up in the OT. People started getting constricted on the table. So I used this drug when people dilated.
Thank you. Thank you for your answer. Thank you.
Is there, Dr. Rajan, is there any study related to the endothelial cell loss following the use of this drug? And if there is any comparison between this drug and the intracameral adrenaline is the drug which is already available and being used by many. Is there any study comparing intracameral adrenaline with this phenocane and in terms of the endothelial cell loss, if there is any study?
I have not read any study like this. Only the entered people can answer about this study.
As far as the action of this drug is compared with epinephrine, this is even faster than epinephrine.
Definitely, sir. Epinephrine doesn't give the full dilatation of the pupil. Yeah. But this gives the full dilatation. You can see it takes hardly 15-20 seconds the pupil to get dilated. Epinephrine doesn't give that much of the effect.
The thing is, just to, because when the pupil, there is intraoperative meiosis. Now, the same drugs that we use for pupillary dilatation preoperatively, tropicamide and phenylephrine are basically the active ingredients over here. So when we have an intraoperative meiosis, that's for two reasons. One is either it's IFIS or it's a prostaglandin release. So to some extent, yes, phenocane might take care in some cases where it's not an IFIS. But if it's an IFIS case, it will be a nightmare because it will keep coming and going. So the phenocane will not be really helping always. So yes, phenocane may help in some cases. That we have to, it is definitely superior to probably using intracameral adrenaline alone, which we've been doing all these years, because it's got the tropicamide part in it. So that's, because if the intraoperative meiosis is because of IFIS, it won't be really of much help because that will keep coming and going.
Fine. So I think if we are done with this, then we'll just move on to the last presentation by Novartis Pharmaceutical. I'll have to do this presentation. Is my slide visible? Are my slides visible? Am I audible?
Yes, yes.
Yes, madam.
last one, that is the dilemma in diabetic eye disease management, lesson learned from the DRCR.net studies. This is a slightly an offshoot of what we've been just reading about. I just go around brief the agenda of the DRCR.net network and the presentation, which is the epidemiology. We'll first go through which anti-VEGF to choose in diabetic macular edema, ranibizumab versus laser treatment protocol I, ranibizumab versus dexamethasone protocol U, and ranibizumab versus PRP in protocol S. These are the 4 protocols of DRCR network that we'll be just reading through. To summarize, diabetic disease is a burden. It's a leading cause of blindness in working age adults in the developing countries. The age standardized prevalence of 35.36 in any diabetic retinopathy and includes to about 11.72% in the visual threatening diabetic retinopathy. 7.48% is that of the diabetic macular edema population and 7.24 of the proliferative diabetic retinopathy. So proliferative diabetic retinopathy and diabetic macular edema develops as a vision threatening stages of diabetic retinopathy. Now extrapolating this data, we get about 92.6 million any diabetic retinopathy in millions. And out of that, 17.2 is the proliferative diabetic retinopathy, 20.6% is that of the diabetic macular edema population, and 28.4 of the VTDM population. The prevalence studied of diabetic retinopathy in India in various studies varies from 20 to 28% on basis of various population-based studies done in India. The foremost pathogenesis is that the harbinger of diabetic retinopathy is the parasite loss. And as you can see here, structural and functional changes in various parts of the eye do take place, which lead to microvascular changes. Hypoxia sets in, and there is release of vascular endothelial growth factor, which is the the foremost important factor, leads to neovascularization and can lead to vision loss and diabetic macular edema. So proliferative diabetic retinopathy and DME can cause vision loss in the various forms of NPDR, proliferative diabetic retinopathy, and diabetic macular edema. The treatment varies with the stage of disease and to prevent development of progression from diabetic retinopathy and diabetic macular edema in NPDR. So the treatment protocol in PDR is prevent further visual loss rather than restoring diminished visual acuity. Whereas in diabetic macular edema, we can prevent visual loss and also improve the visual acuity. Coming to the DRCR.net. So what is it? It was laid down in 2002 and was funded by the National Eye Institute. It is a collaborative network dedicated to facilitating multi-center clinical research of diabetic retinopathy, diabetic macular edema, and associated conditions. Supports the identification, design, and implementation of multi-center clinical research initiatives focused on diabetes-induced retinal disorders. Emphasizes clinical trials, however, epidemiological outcomes and other research may be supported as well. With more than 385 physicians participating, the network currently encompasses more than 120 active sites, including community-based practices and academic centers in 39 states in the US. The protocols that we'll be briefly studying is the protocol IT-UNV, and what has changed the paradigm in A to U is the IT-UNV. Also in protocol JQNSABNW, the protocol that has changed the paradigm is the protocol S. I'll just briefly describe why. So which anti-VEGF to choose in diabetic macular edema is one of the most quintessential questions, which has been answered by protocol T in the published reports in the New Medical Journal, the year 1 study of the protocol T, and year 2 also published in NEJM, which stated that this was a head-on trial between aflibercept, bevacizumab, and ranibizumab, and the visits were every 4 weeks during first year and 4 to 16 weeks during the second year, depending upon the treatment course. The dosage of aflibercept were 2 mg, bevacizumab 1.24 mg, and ranibizumab 0.3 mg. Repeat injections at every 4 weeks. Visit if the eye improved or worsened. Otherwise, defer injections if either the visual acuity by 20/20 or better, and the OCT or the central serous thickness was normal, and resume injection if the visual acuity or OCT worsened. So if you compare the 3 anti-VEGF for DME, we can see that more number of bevacizumab patients require additional laser therapy compared to ranibizumab and the aflibercept group. There was no difference between aflibercept and ranibizumab in the 2 years protocol, whereas when the initial visual acuity was less than 20/50, aflibercept and ranibizumab are more effective in treating these macular edema at 2 years. The protocol at 5 years data also proved that when the initial vision was less than 20/50 OS, aflibercept and ranibizumab are more effective even in the long term, and they had a better gain in visual acuity in latest forms. Comparison of anti-VEGF for DME, number of injections of anti-VEGF required in the second year is less compared to the year 1, and the requirement for injections reduced over the years of follow-up. The quality of life versus cost effectiveness was studied, and ranibizumab is cost-effective treatment option in diabetic macular edema. And protocol T indicated that treatment with aflibercept is more costlier than ranibizumab and yields similar or nominal increase in quality of life. So ranibizumab versus laser in diabetic macular edema, that is the protocol I, which said that it was a randomized trial evaluating ranibizumab plus prompt or deferred laser, or triamcinolone plus prompt laser for diabetic macular edema. So showed that ranibizumab resulted in sustained visual acuity gains that are superior to laser group. It can be seen clearly in the ranibizumab with prompt laser and ranibizumab in deferred laser. The visual acuity gains was much higher. Now the protocol I in 3-year results showed that results suggested that focal or grid laser treatment at the initiation of intravitreal ranibizumab is no better and possibly worse for vision outcomes than deferring laser treatment for 24 weeks or more in the diabetic macular edema involving the fovea and with vision impairment. Protocol I 5-year results showed that although more than half of the eyes in which laser treatment is deferred may avoid laser for at least 5 years, and such eye may require more injections to achieve these results when following this protocol. And most eyes treated with ranibizumab and either prompt or deferred laser maintain visual gains obtained by first year through 5 years and a little addition treatment after 3 years. This was the protocol U of the ranibizumab versus dexamethasone in diabetic macular edema, which showed that a combination and a ranibizumab group, and the results that mean visual acuity by 6 months was no better in the dexamethasone group or the Ozurdex plus ranibizumab group than in the sham plus ranibizumab group. Protocol U also showed a lot of ocular adverse effects, and dexamethasone group had more adverse events compared to the ranibizumab. This is the protocol S, which is showed a comparative ranibizumab versus PRP in proliferative diabetic retinopathy, and the design study was dividing ranibizumab into patients into ranibizumab group and 203 patients in the PRP group. And the primary outcome, mean change in visual acuity from baseline to 2 years, was non-inferiority margin of 5 letters. And eyes in both the groups could receive ranibizumab 0.5 mg for diabetic macular edema treatment. At randomization, this was required for eyes with diabetic macular edema. Significantly greater gains in visual acuity from baselines to 2 years with ranibizumab versus PRP laser was achieved in protocol S. And greater visual acuity gains achieved with ranibizumab monotherapy in studies which showed that diabetic retinopathy with diabetic macular edema at baseline and without diabetic macular edema at baseline. There were also low rates of development of diabetic macular edema in ranibizumab group compared to the PRP group in eyes without diabetic macular edema at the baseline. And 46% of the patients in ranibizumab group showed improvement of more than 2 steps in DRSS at 5 years, maintaining the rates of diabetic retinopathy improvement. Protocol yes also suggested that ultra responders with more than 4-step diabetic retinopathy improvement from baseline with ranibizumab treatment, and the analysis also assessed the results. Also showed responder case of example 1 and 2, which showed baseline case 1 had high risk PDR and now was after treatment was now mild NPDR, and on case 2 from baseline to mild NPDR cases. The age, vitreous hemorrhage, and glycosylate hemoglobin of less than 9% had predictive factors of more than 4-step diabetic retinopathy improvement. And among the eyes with proliferative diabetic retinopathy, treatment with ranibizumab resulted in visual acuity that was non-inferior to PRP treatment. Cost effectiveness, the study has been published, and ranibizumab was found to be more cost-effective treatment for eyes presenting with proliferative diabetic retinopathy compared to pan-written photocoagulation. So the conclusion of this, no difference was found between ranibizumab and aflibercept in the management of diabetic macular edema compared to bevacizumab protocol T. Ranibizumab is more cost-effective option compared to aflibercept in protocol T. Ranibizumab treatment is associated with greater visual acuity gains compared to laser in diabetic macular edema protocol I. And adding dexamethasone to ranibizumab did not provide any additional benefits compared to ranibizumab, and dexamethasone have lower safety profile. Patients with central involvement diabetic macular edema with visual acuity of 20/25 can be observed without any treatment. It was suggested in protocol B. And 46% of the patients in ranibizumab group showed improvement of more than 2 steps in DRSS at 5 years, maintaining the rate of diabetic retinopathy improvement in protocol S. Thank you. If there are any questions, I would now request Dr. Rajiv Gupta sir to. Dr. Rajiv Gupta sir?
Yes.
Sir.
Am I audible?
Yes, sir, very much.
Yeah.
Okay.
So,
Gwalior Divisional Ophthalmic Society is really happy to have you all at our platform. It's really nice to hear from all the learned speakers. Thank you very much. I'm specifically thankful to Dr. Suvin, who has taken up valuable time. Thank you, Dr. Suvin. You are with us. We have learned a lot from you. Thank you all, Dr. Rahul, for his specific, line, the poor man's femto good. And Dr. Purendra is our own very good speaker from Gwalior, Dr. Manav, Dr. Vijay, Dr. OP, Dr. Prajakta. We are really very thankful to you all. Thank you so much, and especially I would like to convey my thanks to Ento team, who has given their financial support to this webinar. Thank you all. I'm really grateful to our enthusiastic, hard-working Secretary GDOS, Dr. Manav, who has really worked very hard to organize this CME. Thank you. Thank you.
Thank you, GDOS, and thank you, Manav. Thank you very much.
Thank you so much.
Thanks, everyone. Thanks, Manav, for conducting it so beautifully. Hello.
Valuable time.
Thank you, Manav, and thanks, Raju, for putting all in efforts.
I think it's an excellent team, sir. The President Secretary is an excellent team. I would like to congratulate Gwalior Divisional Society for hosting such a wonderful event.
I'm taking a minute of you all, please. Professor Tiwari, sir, a special moment is coming to you tomorrow.
Yeah, that's right.
Dr. Tiwari, sir, is retiring tomorrow. Definitely, we would like to convey our best wishes to him for his new inning. Professor Tiwari,
Thank you very much.
Congratulations, sir.
Thank you very much, Raju, and thanks all all the members of Gwalior Divisional Society and the other members of ophthalmologists for all your good wishes. I am still there. मैं इतनी जल्दी पीछा नहीं छोड़ने वाला आप लोगों का. I'll be here only. Yeah. And as and when you will call me, I'll be available, and I will love to interact with you all. Thank you.
Sir, even if you decide to the desert, we will not be allowing you to go up from far away from us.
Sure. Thank you very much.
Our best wishes to you.
Thank you. Thank you.
Thank you, everybody.
Thank you. Bye-bye.
Bye.
Thank you, sir.
Good night, sir.
Thank you and very good night to all the participants.
Good night. Good night to all of you.
Thank you so much. Good night. Good night, Manav. Good night, Rajiv, sir.
Good night, Rahul.
Bye-bye, sir.
Bye.
Good night, sir. Thank you very much, sir.
Good night, Dr. Prajakta. Good night.
Sir. Thank you
Good
very
night,
much.
Doctor.
Bye-bye.
Good night.